So thank you everybody for making up time to join us today. Chat about diabetes and all kidney stuff. So we're going to be kind of directing you to lots of places so that you can get information. As a kick-off, just wanted to warm up. So in terms of type 1 diabetes, and I'm going to talk about type 1, and then a lot of the rest of the afternoon will be on type 2. But just thinking about your type 1 population, what do you think is the biggest risk factor in terms of having the poorest HbA1c? Okay, so multi-choice, hands up for gender. I assume you've all got a left and right hand. We're going to see hands go up. Okay. Age. So a handful of votes for age in this corner. Ethnicity. Okay, back corner away. Now this side, you've not voted at all. Does that mean that you're all going for deprivation? Okay, interesting. So the biggest risk factor is actually age. A few people over there. So, as Tom was saying, where's he gone? Tom was saying that young people really struggle to access care. And we did an analysis, this is a national analysis of children and young people, and we looked at their HbA1c from the age of 5 all the way up to 30. And you'll see that the worst age is 19, whether you're male or female. This is the median. The median, obviously, is just the middle person in a queue, but it's the middle person of whom we've got data on. So nationally, 20% of young people aged 19 have not had one HbA1c check in the last 3 years. So if you imagine what their mean must be, you know, they're not going to be sitting there with good control. They're going to be 85, 105, 130. So the mean is going to be much worse than this median. And because we're looking at 90,000 records, and we know all their postcodes because we've dragged all the data out of GP records as well as specialist units, we know that age is a bigger predictor of worse outcomes in terms of HbA1c than ethnicity, gender, or social deprivation. Okay, so it does go up. It goes up with puberty. The girls have a particular spike at around about 15. So we're working very closely with the Children's Hospital trying to make sure that young people with type 1 are transitioned safely to adult services. And so what do I want you guys to do? I want you to phone a friend, because this is complicated, and we don't expect you to keep up with all the nuances and the changes in type 1 diabetes care. So the number on screen is the number to our diabetes centre, and we do have a triage system. So if you're asking complicated medical questions, you will get put through to the consultant on call. If you're a nurse and you've got a quick question, then you may get through to the nurse on Gateway, but Gateway is designed to avoid admissions. And there'll be somebody rotated this afternoon, and Debbie and Bridget, I'm looking at them because they do this job and I don't. But you know, it's one of those jobs you go, oh yes, I'd love to do next Tuesday, because you just never know what question's coming in. What they're there for is to stop admissions. So discussions about ketones, discussions about severe hypos, not about insulin titration, not about should I do this test or that test. We have other mechanisms for that. We have the advice and guidance. So this is kind of like an emergency phone number. But if you've got a young type 1 in front of you and you think you're about to, get them to engage and you know that we've never ever seen them, then do pick up the phone, because the reception staff might be able to find, sorry, some photos are gone. Yeah. Sorry, it's not quite the presentation that I thought. So I did have photos of our four young diabetes nurses. So we have 4 nurses now. The full-time job is to try and look after young people with type 1 or type 2 diabetes under the age of 25. And So they get phone calls from all around the different specialties. So we do have the majority of people coming in from paediatric services, but we do have people rocking up to eye clinic who then get told they've got eye disease and we get a phone call. Yes, we've had phone calls from our local prison service or from the eating disorders. If we've got the only eating disorder or psychiatric bed locally in the country, then they would come there. And we will engage with all of these services and obviously with yourself. We know that not every young person will come to the hospital, but if we get 90 or 95% people into secondary care, we now have enough staff that we could visit a handful at home, and that's what we have done. But we can only do that if you tell them about. We need to know about, from you guys. So one of the local GPs said, I've got these 2 young girls, got severe learning difficulties, and we managed to send out nurses to go meet mum and these 2 young girls, and we've managed to get one of them into clinic, and we've stabilised things. And I've clapped eyes on one of them, but generally they're now accessing care. So we do have more than one way of doing this. Okay, so you'll be aware, I'm sure, about Libra devices and Dexcom devices, and I can see Jude is here at the back. So if you've got any questions about this kind of device, do go and chat to Jude in the coffee break. When people are doing finger pricks for you, we hope that they're in single figures, but they're not too low. But what you just get is the 4 points in time, and you don't get to see what the glucose is doing in between those points. So what you don't see are the high glucose levels that are happening, and what you might miss are also the low blood glucose, the hypos. So now we have these sensors, and so Libra and Dexcom are the 2 most common ones. There are other ones coming onto the market, but these are ones that we use predominantly. And yes, they work through smartphones, and in a way it's easier if they're using a smartphone because then the data goes to the cloud and we can look at it remotely. But there are lots of people who don't have smartphones and they might get on better just with a handset. And both companies have given the Diabetes Centre loads of these handsets. So we're happy to support all people with type 1 diabetes accessing these kind of devices because it helps us adjust their insulin. Some people, I know, between you, you've referred in and you'll say, oh, this person's not been seen in secondary care for 20 years, but they're interested in a Libra. What happens is that I send a task via System 1 to our admin team, ask them to send out a Libra and some instructions. If they're a little bit older, I'm not going to tell you what my cutoff is, but if they're a little bit older, I'll say, do you mind just giving them a ring and seeing if they've got a smartphone, if they're happy setting this up themselves, or they like a face-to-face start. So we have some older people who come in, perhaps with a significant other, or we've had a grandchild come in with granddad to get him started on a Libra with his iPhone that he didn't know how to switch on. But those are the kinds of things that we can support. So HbA1c is not all the story. So over on this right-hand side, you can have an HbA1c of 53 that might or might not get automatically filed in your systems, where, yes, they might have 100% of their readings within range, but much more likely is that they're having some hypos and hypers. Now in the middle, we've got somebody with a low amount of hypoglycemia, so you're allowed a maximum of 4%, which is still an hour a day, but it shouldn't be any more than that. And to get a really good HbA1c, you need 70% of the readings within range. But the HbA1c of 53 might be hiding 20% hypoglycemia. So the HbA1c just tells you a little bit, but doesn't tell you about where the glucose has been or where it's going. We will be using HbA1c for quite some time because it's the best predictor of diabetes complications. But in the short term, when you're making suggestions about how to change the insulin, you need to be thinking about the time in range. Now, between us and the front table, we've looked at hundreds and thousands of these traces, and it does become a lot easier. But your first job is not just to think 53, good, tick, but for your type 1 patients and people on these devices to be thinking about, I wonder what their percentage hypo is. And I'm going to show you, hopefully the next slide, has got that displayed. But in the meantime, I want you to just do this bit of maths. You've already had your lunch, I hope. It's coming up to tea time. You've got 50 grams of carb. You've been told by your lovely DSN that you need 1.5 units per 10 grams. Your glucose, unfortunately, isn't in target because you had a snack at the coffee break. And you last injected a bit of insulin 2.5 hours ago. How much quick-acting insulin are you going to inject? Who's going to be brave and give me a number? So stunned silence. But by the way, your spouse is getting pretty hacked off by now, saying, come on, decide how much you're giving. The tea's getting cold. Okay, so the maths that you should be doing in your head is thinking, well, it's the ratio times by the amount of carbohydrate. Then you're thinking, oh, but my glucose isn't in target, so I need a bit more insulin to get to the target level. The bit of information I didn't tell you was your insulin sensitivity factor, which is either 2 or 3, usually. And you've got to work out how much of the last units you had 2.5 hours ago is still working. And at the end of that, you should have all shouted, 10! But it's not easy, is it? When you're put under pressure, not many people can do that maths very quickly. And yet that's what we expect all our people with type 1 diabetes, and we know we're talking about a wide cross-section of people that may or may not be very numerate, but that's what they need to do each mealtime. And yes, they could put it in a bolus calculator, and you could have got your calculator out on your phone, but imagine doing that every single time that you were about to eat. So it's not surprising that a lot of these results don't end up in the target range of 4 to 10. So we have the recommended targets here. You're meant to spend 70% of the time between 3.9 and 10. Let's just round it up, 4.9 to 10. No more than 4% under 4, 1 hour. For older patients or more frail patients, you will see in letters that we're writing that 50, 60% is fine. We're not trying to push these people towards getting 70%. For those kinds of people that are a bit more fragile, hypoglycemia is even a bigger risk because they fall over, they break their hip, they spend weeks in hospital. So that's why it's only 1%. Pregnancy, tighter targets. For type 1s, 70% between 3.5 and 7.8. For type 2s, we're trying to get well above 90% between 3.5 and 7.8. So what can you do to help? So because this is remote data, and I was at a conference last week, I thought, I'll just go and find somebody whose control doesn't look very good. So this is somebody that I've never met. Their HbA1c is predicting a 58. So if they were bled last week, it would say 58, and you think, okay, that's fine. But look at the amount of hypoglycemia that she is having. Massive amount. And this number you can get off the smartphone. So I'm not asking you to look at individual days, but if somebody's coming in with a smartphone or with a handset, you ask to look at the time in target. You press the 3 little bars at the top to get into the menu, and then it says time in target. And then you get the picture that we've got on the right-hand side. If you see this, that's when you need to refer in. They need less insulin somewhere, and it could be that the long-acting needs reducing, it could be the quick-acting needs reducing, it could be that both need reducing. But the only way of knowing that is to go into the individual days and have a look. So, and obviously I know that you're very, very pushed for time, that's not what I'm expecting you to do, but it would be good if you could explain to the person in front of you, this high level isn't good, you're not meant to have more than 4%, you do need a review. I'm tasking the team at Sheffield to get you reviewed sooner rather than later. Do pick up the phone, do make an appointment. Otherwise, we just meet them in a heap in an ambulance and have severe hypos. And when I saw that, I sent a task to whoever was on Gateway last week, asking them to contact said patient, and they will have had a look at the data and adjusted the insulin. And the good thing about that is, when you make a change, that time in target will look very different in 2 weeks' time. It's only looking at the last 2 weeks, unless you change the settings. Whereas what the HbA1c does is change very slowly over 3 months. And it only tells you about the risk of complications. It doesn't tell you about the hypos, doesn't tell you about the hypers. So you will see and written in all the letters about time and range and percentage hypos, because that's where we're making active changes to the insulin regime. Okay, so in the next few weeks, there will be a national announcement, and some of your type 1s might crawl out of the woodwork that you've not seen for ages going, I want one of those. So there was a big hoo-ha in January where they said 100,000 people would qualify for the artificial pancreas. Well, from what I've heard, they may even increase those numbers. So it will hit national newspapers in the next few weeks, depending on the timing and the funding that NHS England talk about. Even if there's no funding, it'll still be front page news. So you're going to get questions about this. And what we're talking about now is an insulin pump. So these are the two that we prefer in Sheffield. So there's a tandem pump that is smaller than your mobile phone. It's about the size of a bleep. If you can remember carrying a bleep, that's the size of a tandem. But it's got some tubing and it's got a cannula on the end. And that delivers insulin. And it just delivers quick-acting insulin all the time. The other one you can see at the bottom here is called an Omnipod patch pump. And it's a patch pump because there isn't any tubing. And so lots of people prefer just wearing a patch because there's no tubing to get snagged on anything, at work or toddlers. And the real advance now is that the sensors are good enough to talk to the pump. And if the glucose is rising, they tell the pump to increase the rate of insulin. And if you're busy cycling, turn around Sheffield, and your glucose is dropping, it will slow down the rate of the insulin infusion and perhaps even stop it for a few minutes. And the maths, the complicated maths, is happening in the smartphone, or in this case in the pod itself. It's making decisions every 5 minutes. Do I need to speed up or slow down the insulin or stop it entirely? So this is the nearest thing to a cure that I think I'm going to see in my working lifetime. I hope there is a cure before I demise entirely. But certainly this is the best thing over the next 10, 15 years. And it's our collective job to help as many people access this as possible. So if somebody comes to you and goes, I want one of those magic pumps, artificial pancreas or whatever the different newspapers call it, do refer them in. Because we'll be saying, yes, we need to get you started down that route. It's not a 5-minute job. It won't happen on the first appointment. But it won't happen at all if they don't come and see us. So they come and see us, and we start that process of getting them monitoring, making sure they're on the right equipment, trying to gain some idea of the amount of insulin that we need to program into these pumps. So in terms of the glucose, what can you expect? So we in Sheffield were part of the national pilot, and we were asked to find people that were on insulin pumps but not very good control. And this young man, he works in the film industry, and he flitters around. So the first time we met him, his pump was half broken. He said, can I have a new one? And I said, well, this is obviously well loved and dropped and bashed, but you're not making very good use of it. But you have turned up at just the right time if you want to be part of this trial. But you have to stay in Sheffield for 12 months so that we can sort this out. And so you can see the squiggly line. It's not between 4 and 10. You can see his time in range, 39%. And then within the first 2 weeks of going on to this new system, that's what it did for him. So what it does is get the glucose into range so that people wake up with a good glucose every single morning, and then during the day, he will be telling the pump how much carbohydrate he's eating, or his best guess, and it will just buffer. And so if he ate 40 grams, if he told the pump 40 grams, but instead he ate 50, it would just slightly increase it. If he got interrupted, got an urgent phone call, didn't finish his meal, it would switch off and hopefully avoid the hypoglycemia. So that's him, and this was one of the easiest talks I could do because had so many examples. You know how people pick the best example? I just did the first one. So this is day one, when, not being rude, me and my team didn't know that much about the system. In terms of HbA1c, he went from a 71 to a 48, and he's still close to 50, and we're now 2 years on. And he's telling me that, you know, his job was a lot easier. He's now back round, flitting around the country, making wonderful films and basically leading a normal life. And in terms of was that a fluke, these are the Sheffield results. So everybody had to have an HbA1c above 70, and you can see that we've got it down at 6 months, it's maintained at 12 months. And because we'd spent a lot of time with people, we didn't have that many older adults that needed this kind of tech, but we did have more than our fair share of youngsters. So I thought, well, how many did we have? 17 to 25. And you can see they started a little bit higher, but actually got slightly better results. So this works very well for young people as well as people that are a bit more expert and got better routines. So that data, we were one of 20 major adult centres, has now been published. And they're called violin plots. I really like these. It gives you the width, gives you the idea of the number of people that were at that point. But you can see a whole population of people, 420 people, have suddenly got an HbA1c of 19 millimoles or less, being much better. And their time in range isn't perfect, but it's about double what it was. Okay, change of tack. These people would love to sit down, and they can do in a couple of minutes, but in the meantime, can the rest of you all stand up? Okay, you're allowed to sit down if you know that you've forgotten something today. Okay, yesterday, in the last week, that was me, okay. Okay, and the others got too embarrassed, which is good, because if anybody was stood up at never, I'll go, well, these are the people that can't remember that they forgot something. But I did that at an international conference, and it was full of consultant diabetologists and researchers around Europe. And that we were doing it by, Slido. But that's what they said. And I asked the question at 11:30 in the morning. So, as intelligent and together as you guys are, and presumably that audience, it's very easy to forget stuff. The same happens if you've got diabetes. You forget stuff. You forget if you gave the last insulin dose, and if you did do it, how much did you give? And so we are using more of these smart pens that record the last dose. You can have half unit ones or full unit ones. There's different colours according to the doses of insulin that you need. The batteries last 4 or 5 years. And so, even if you've got something that's not very techy, I had a lady who'd had type 1 for 62 years, and I showed her one of these pens 2 weeks ago, and she went, wow. I don't get that very often in clinic. So it does make people smile. And what it means is that people can have reassurance what the last dose was and that they didn't double dose, or did they just forget entirely. And if they're looking at their CGM at the same time, that's really helpful. You can link the two together. Fairly easy steps. You're going to get these slides, and I'm overrunning, so I'm going to speed up. And in terms of what we look at the daily trace. We try and second guess what the person has done with their insulin. But if we've got the actual doses, then we know what's happening. And the answer to this one was he went hypo because he was busy walking to this very football ground on a Tuesday night, and he'd only had diabetes for 3 weeks. And he said to me, oh, does that mean I need less insulin next time when I walk into a football match? So it helps them make connections very, very quickly. Last but one slide, I think. So COP26, when that happened up in Glasgow, we in the diabetes team thought, what can we do to try and reduce the amount of plastic waste that we are adding to the system? And we thought, let's make sure that everybody that we start on insulin goes onto cartridge pens as opposed to disposable pens. And so there's some ridiculous statistics, something like if we don't change our prescribing habits, then in the UK we will have prescribed enough pens to go around the globe 28 times in the next decade. So anyway, we decided we'd switch, and you can see that rather than the amount of disposable pens continuing to increase or percentage cartridges decrease, we've got the percentage amount of insulin prescribed in Sheffield increasing in cartridges. Please help us with this. You're the guys writing most of the prescriptions to help with that. Oh yeah, and by the way, by the time we had a look 18 months later, we'd saved the weight of 6 baby elephants in plastic pens. You're going to get a copy of these slides. There's not too many of the reusable pens. You've got all the different insulins on the left-hand side. Those are the pens that you need to prescribe on the right-hand side. Lots of your patients will have been on cartridge pens years ago and can't remember why on earth they were switched to disposable pens, and they're more than happy to switch back. If you say plastic grandchildren climate change, I've only had 2 people just go, not sure about that, and I've managed to get them to switch 1 out of the 2 pens. Everybody else is just switched, and it's not a hard sell. So, just to summarise, please refer everybody in under 25, type 1, type 2, don't know what kind of diabetes they've got, steroid, whatever. Everybody under 25, we've got extra resource to cope with it. Refer in all your type 1s, we'll get them on the CGM somehow. Make sure that you do look at the time in range on these devices when they come into your clinics. Think about moving people onto cartridges. One thing I've not mentioned is every year we get 2 or 3 patients writing to us saying, my GP/pharmacist/nurse has stopped my insulin, I've got type 1 diabetes, please can you write back to them? So some of these people now on these special systems will get very low HbA1cs without any hypoglycemia, but they definitely still have diabetes. And if they've got type 1, of course, they do still need their insulin. So just be careful that you haven't got somebody that's a bit trigger happy and stopping insulin a bit too quick. Double check, have they got type 1? Otherwise, they're going to come in DKA. And don't ignore the plastic mountain. Thank you very much.